To assess the anterior hip, we can put a pillow underneath the patient's knee to relax the structures at the front. First of all, we follow rectus femoris in transverse section until we see its attachment, which is the direct head, onto the top of the AIIS. If we move the probe medially and the most medial aspect of the probe slightly distally, then we can see a nice structure, nice white hyperechoic round structure, which is the psoas tendon. It's important to get our anatomy correct here. So you can see the AIIS on the right hand side. We can also see just superior to that the lateral iliacus, muscle belly, and then just underneath the hyperechoic line, which indicates the intramuscular tendon, is the medial iliacus. And just under that is the psoas tendon. It's important to tilt the probe to get the tendon nice and bright. Now, if we move medially, we see a nice landmark, which is the femoral artery pumping away there. And that's a nice landmark because underneath that is the psoas muscle belly. If we move more medially, we can also see the hyperechoic line of the pelvis there, but on top of that is the pectineus muscle. So it's important to orientate ourselves in a transverse section. Once we've orientated ourselves, for example, we can spin on any of those structures. So if we spin on the psoas tendon, we can see the psoas tendon sitting on top of the hip joint. You can see the femoral artery, you can see the pulsations above that, but we can see the nice fibrillar alignment of the psoas tendon. Now, it's really important to look carefully at that tendon, particularly above the joint, because sometimes we can see fluid around the tendon and we may think that that's bursal fluid, but actually a lot of the time, just like in the long head of biceps around the shoulder, we actually see fluid around the tendon, but it's coming from the joint itself. If we go back into transverse section, we can also see that tendon that sits nicely on top of the joint, and you can see between the articular cartilage and the psoas tendon is the capsule of the hip joint. If we go back into long section, we can also see just the small hyperechoic region there is the labrum. Now, if we follow the articular cartilage, trying to keep the bone nice and bright, we can actually move distally until we see the femoral neck. Now, it's really important to look for a cam lesion in this longitudinal section, which would be located just above the neck of the femur. Now, if we slide down, this is where we carry out hip intra-articular injections, and it's important to measure the anterior capsule, which is the iliofemoral ligament. And some of the studies show that more than 7 millimeters, some talk about more than 10 millimeters, may indicate some thickening and some synovitis. And if there is an intra-articular effusion, then it generally accumulates down the neck just underneath the anterior aspect of the capsule, where the arrow is pointing to now.
Now let's go to the more superficial layer around the greater trochanter. So what we have already gone through in the previous video is the gluteus minimus and medius tendons. So just a brief reference to them. The anterior facet of the greater trochanter with the minimus on top. Go to the lateral aspect, line up the tendon there, which is then parallel bend. That's the lateral facet of the greater trochanter, and then if this straight looking posterior facet is for the posterior band of the gluteus medius. So that's your deep layer. Now, between the deep layer and the superficial layer, there is a bursal plane, and like in the rotator cuff in the shoulder, there could be potentially bursitis or swelling occurring, and that bursal plane, and that's what you have to bear in mind, goes fairly far posteriorly. So don't underestimate how far posterior it goes. I'll demonstrate it in a minute when we do the dynamic test. So we go to the anterior part first. So that's your anterior facet again. So that's the fascia, tensor fascia lata on top. And if we go posteriorly, you can see the two layers still on top. And here the muscular fibers of the gluteus maximus will be visualized. So the main thing now is to do a dynamic test. So we go back to the beginning and ask the patient in this position, lying on his side, to lift up his foot and go back. Do it slowly so you can monitor and see what happens. So in that plane between the two layers is where you would find some fluid. And you can follow that more posterior if the patient keeps moving. And now go to the posterior side, keep going, keep moving. And you can see how far back, you keep going, how far back you need to go to see that plane continue. There's often the posterior part is where the fluid accumulates as the pressure pushes it into that area. Stop there for a minute. Also bear in mind that bursitis on the lateral hip is not as common as is often thought. So you can often see tendinopathies or any other changes, but purely a bursitis on its own is not common. But it does not mean that you can look for it and assess it on ultrasound. It's just not as often found. And that's it. So that's how you assess the superficial layer, going over the deep layer in the lateral hip, looking for bursitis or swelling or any tendinopathy that is occurring in that area. Let's talk you through how to assess the indirect tendon, the central tendon in the rec fem. And the starting point is always find bony, or in this case also soft tissue landmarks. We start about halfway up the thigh and you identify the 4 compartments: vastus lateralis, vastus intermedius, vastus medialis, but also then in the middle there, the rec fem, rectus femoris. Once you have identified that, trace it up slowly and start looking for the central tendon that will form within that rectus fem belly. There it is. Now as we go further proximal, it is quite clear. Now one good tip, because it's in such an oblique plane, work the probe and make it really quite bright if you want to assess the tendon itself, because it's very easy, especially if it's in a vertical plane, to change the details that you can see in the tendon. So use your probe to your advantage there to really scrutinize that tendon. And the same counts for the tissues just next to the tendon. You can make that look quite dark, these muscle fibers here next to the tendon, and it might be difficult to judge what's going on. So either press down a little bit, flatten out a little bit, or work your probe to get a really good impression of those tissues, the central tendon as well as the muscle fibers next to it. And then we trace it up further proximally. The direct tendon will form from the anterior fascia, which is not really visible as a tendon as such. At this stage, we're going to continue to go proximal. Here again, I have to make sure that the tendon is visualized by angling my probe, and the tendon will just continue to form as it goes up. Then the anterior fascia will draw together with the central tendon, getting quite proximal now, and muscle belly is falling away. And if we trace it further, we will see the attachment of the direct tendon. And if we come back a little bit distally, we now see the shadow of the indirect tendon. So we need to move our probe laterally and line up, push it down so you can see the fibers going through. And you can sweep through this one because you can see the direct tendon there, the indirect tendon coming lateral, and below that is the capsule. We're here at the joint line. You can see the articular cartilage, then you see the capsule, and then you see the indirect tendon. And it's quite important to see that interaction and see each individual tissue in order to assess that. So that's how we do that, and we start distally just to make sure that we follow the muscle, then the tendon, all the way to the insertion, so we have the entire structure assessed and we don't miss out on any information. We're going to talk through the proximal hamstring, and we start on the medial side, identifying the fascial plane. All this is adductor magnus with a small tendon of the adductor magnus there. So we're going to first identify the musculotendinous junction of the semimembranosus, which is a triangle that starts in this area here, and it gets bigger as we go distally. I'm going to go back proximally, and then big distally, you see the membranosus muscle coming up. You follow the deep fascial plane, and then there's a tadpole, like a nodule in the fascial plane, which is the semimembranosus tendon, and then we follow up further laterally. You see the next structure is the sciatic nerve in the fascial plane, and we follow the fascial plane all the way to the lateral side until the end of the compartment. Go back to the sciatic nerve. Above the sciatic nerve is the conjoint tendon of the biceps and the semitendinosus. Semitendinosus on the medial side, and we can see in intramuscular raphe of the semitendinosus when we go proximal and distal. Now, once we have identified all the structures, we're going to move it up proximally to see if we can follow them up to the attachments. So, conjoined tendon, semimembranosus tendon, and they're going to move slowly towards each other as we go proximal. Sciatic nerve stays where it is. And there it comes. We go up until we reach the bone. And the attachment there. Now that's an oblique picture, so we need to move the probe and so we can see a little bit better its footprint. And on the lateral side is the sciatic nerve. When we spin on it, we can see the longitudinal aspect of the hamstrings. And with this, we need to bear in mind that on the medial side, there's a short tendon and a muscle belly identified next to it, which is basically the muscle belly with semitendinosus. Semimembranosus lies more lateral and is a thick tendon. So that's the way to identify both structures. Medial, muscle belly with a short tendon, semitendinosus.
Okay, so following on from Carlos's talk, looking at adductor longus injuries. Again, it's the same principle. You've got to know your anatomy, you've got to find the anatomy, and you've got to follow it all the way proximal to distal to ensure you don't miss any injuries. So all we're going to do in transverse section, just behind the adductor longus tendon, is we're going to identify the gracilis, which is a really nice soft tissue landmark to start with. If we move slightly anteriorly, we can see the adductor longus muscle, and this is the intramuscular, the proximal intramuscular tendon that Carlos was talking about. We're just going to orientate some other regions. So this is the adductor brevis, and this is adductor magnus. So you can see gracilis at the top, longus, brevis, magnus. If you're not sure, just follow it down. Brevis, if you just follow that down distally, it's a very short muscle, and you can see there it goes to a very small column, and now all we've got is adductor longus and adductor magnus. Now, we're going to really scrutinize this adductor longus in cross section. So you can see the muscle belly here. It's really important to toggle the probe to ensure you avoid anisotropy, particularly of the tendon, but also the fibers around the tendon. This is the proximal intramuscular tendon. Now, if we follow that down, you'll see it gets smaller and smaller until it disappears. And then we can follow it back up proximally all the way up to the pubis. So you can see it goes from the intramuscular region and it heads up towards the superficial fascia of the longus just before it attaches on to the pubis and the pubic tubercle. Now you can see the longus getting smaller and smaller, and then it attaches onto the pubis. We can also follow that in long section, which can be a bit trickier. So if we just rotate the probe, you can see the intramuscular tendon there of adductor longus, and we can follow that up towards the pubis with lots of gel, bit of pressure, and then you can see the intramuscular tendon comes down and forms the free tendon and the attachment onto the pubis there. And even in this position here, you can see the three muscles, longus, brevis, and a little bit of magnus there.
Did you find that video useful? If you did, don't worry, we've got loads more videos for you. You can like our videos, you can make a comment, you can subscribe to our channel to get all of our new videos, and you can even join our membership. Good luck scanning.